Our first presentation features Dr. Enrique Alvarez. Dr. Alvarez is the Vice Chair of Clinical Research at the CU Department of Neurology, Associate Medical Director of Outpatient Neurology, and Associate Professor of Neuroimmunology at the University of Colorado. Dr. Alvarez today is presenting an update on COVID-19, vaccines, and MS. Dr. Alvarez has a lot of information on his slides, so I want to remind you that you can always download the slides that we archive afterwards if you'd like to take a closer look. Thank you so much, and welcome, Dr. Alvarez.
Excuse me. I think she meant I had really complicated slides, so hopefully I can explain them okay. Awesome. All right. Well, thanks a lot. I was really hoping this might be our last COVID update, but it's nice to see a lot of people here. Seems like we got like 1,000 people in the audience, so that's awesome. We'll talk a little bit about numbers, risk factors. I think a lot of this stuff just kind of updates for people that have been listening to these. We'll talk a little bit about third doses versus boosters, some myths, and then guidance, which I'll give the punchline right now: get vaccinated. It's easier to do that than to try and get people to be younger, become women, fix disability, and other things like this that we know can also reduce risk. All right, so where are we at nowadays? So it's hard to keep track of numbers. You'll hear a lot of news. You know, the US is coming way down. So I think, you know, the headlines over the last few weeks was really positive and making it seem like we were doing really, really well. Except for you're starting to kind of see this plateau, and we'll get into that in a little bit more detail. UK had done awesome, and we could see where they're kind of ranking as far as number of cases as well. Europe and other areas, you know, doing okay, although starting to kind of see spikes in some of these areas as well. So cases we care about, but I think what we really care about are deaths. And this is going to be a running theme throughout the discussion today, that, you know, it's not just about sort of that little sniffly nose. I mean, we don't keep track of colds, and we don't wear masks for colds at this time much, but we do care about deaths, intubations, you know, patients having to get intubated in the ICU and things like that. And here we're not doing so well. This is the difference between us and the other parts of the world. And so there could be a lot of different reasons for that, and we'll get into some of those reasons. These are coming down, these leg cases, by a couple of weeks. And so this plateau to increase, we're probably still not seeing, and will probably be hitting us in the next few weeks or week. So where are we at in the US? This looks a little bit opposite of where we have been, where this area tended to be really dark. Here we looked okay for the most part. We could see we're kind of in the midst of where it's not looking so hot. Alaska included in there. So where are we at? So as far as number of cases, it looks like that kind of snuck up in there. You could see the cases, but this is to mean the number of ICU beds available in our state. All beds available is up here. So this is for like everything. And you can see where we're at now, where we were at the peak. And our peak is going to projected for Colorado at this time to be higher than the peak that we had at the highest last winter. And we're approaching to basically taking over half the beds in the state just to take care of COVID patients. You could see the shaded area represents a wide range, meaning we could end up really bad, or we may end up not so bad. And some of that depends on things like mask use, how cold the temperatures are, how much time we spend indoors, outdoors, and of course, vaccination status and things like that. ICU beds, you can see it's going to match up or probably exceed where we were at and get really close to exceeding our beds. And this does not reflect sort of areas by states. And so areas like Puebla announced that they're out of ICU beds. So we'll talk a little bit about that here in a little bit more. So where are we at as far as Colorado goes? We can see that per number of cases, we're not doing terrible, but we're a little bit more of a populated state. So per 100,000, doing okay. When you start to look at number of deaths compared to the other states, we're doing a lot better. And you can see that part of the reason as far as that goes is probably because our percent vaccinated in our state is doing really good compared to being in the 40s and 50s. And you'll see that areas that have a lot of cases, but kind of relatively lower death rate, have this relationship with how much vaccine have they gotten. So we're in the top 5 states, and that led to, issues about having to, for example, implement new guidelines for hospitals, new tiering. And so we made to this tier where right now the hospitals can move you around from hospital to hospital without you getting much of an input on it. So if we need a bed in a patient, a hospital that can take care of you a little bit higher, that's okay. They'll just move you. Part of this to realize it's like wearing masks suck, but imagine the people working in the ICU having to wear respirators, face shields, gowns, and gloves for 12-hour shifts. As we look at this, last week, Monday, there were 900 beds in the entire state still open. How did we even allow for 900 beds? Basically by canceling a lot of procedures. So a lot of colonoscopies and other procedures like that are getting canceled. One of the orthopedic surgeons on our campus had this quotation in there. Let's say a 16-year-old with an ACL tear. If you delay that, you're subjecting them to not only prolonged inactivity and potentially depression, but also to possible meniscus damage and arthritis down the road. So this is kind of what's happening to the healthcare. We're getting a lot of trickle-down issues that are kind of coming up. So let's look at risk factors. So age, this still remains the biggest issue, even beyond sort of immunosuppression at this point. Over the age of 60, 65, somewhere in that range, really the numbers start to kind of go up, and we'll see that a little bit more. Males have a 2-fold increased risk. These comorbidities start to kind of, as far as their effect on death rates and things like this, are much lower. Disability level, start thinking about kind of reaching sort of wheelchair level and higher, maybe walker a little bit. Below that, very little risk associated with that. And then treatments. We're starting to learn that interferons actually reduce the risk of it's actually probably a treatment in some regards for COVID, not maybe a great treatment from an MS perspective. And B-cell depletion, S1P inhibitors, appear to increase the risk of at least being intubated in an ICU or at least hospitalized by 2 to 3-fold. But we're not seeing that at the level of death. And as mentioned in some of these prior ones, that probably has to do because as the COVID infections get really bad, this is actually one of the things that leads to death is a runaway immune system, and this might help control that immune system. So where are we at in the state? Here you can see again these curves and kind of approaching where we're at. If we split that out by age, this kind of highlights a little bit the differences that we're seeing in age. You can see in the first wave how it really, really affected those that were over 70 years old. We're not seeing that quite anymore. And what's the big difference between that group and this group? The running theme for today. They got really vaccinated. This group has been vaccinated almost into the 90% range. This group here is lagging around, usually around the 40 to 50%. So that's the big difference. A lot of different risk factors. I mentioned some of these early. For people who want to look at it and kind of spend a lot of time, you're welcome to. I'm not going to get into that. We've talked a lot about variants, and there was a lot of concern about what other variants might be coming around. Right now, in the US, in Colorado, there's one variant. It's the Delta variant. And there was a lot of concerns about things like mu variant and things like this that might be resistant to the vaccine. But right now, the big one that we're concerned about is this. What's the big concern about runaway numbers the way that we have them right now? The higher the viral numbers are, the more chances that the virus mutates and you end up with variants. When did all these variants develop? They develop basically at the top of the other peak. And so the concern might be that after these peaks, we might end up with other variants that come around. The vaccine is very effective against the Delta variant. Let's look at Colorado and kind of some heat maps. So where are the number of cases? Where are the number of vaccines? You can see these heat areas around the Pueblo County and Mesa County. They also don't tend to have areas, they're the areas that tend to have the lowest counts of vaccine rates. Here you can see, and I don't know these counties, so I apologize for people that are in these counties, but you can see in this county, for example, has much higher rates of vaccine compared to the 3 counties around it. And its rate of cases is lower than the 3 counties around it. Mesa has a high rate of, or this county here has a nice rate of vaccination and lower compared to the surrounding counties around that. So it's easy to see these on maps about the effects of vaccination. We know we're talking about the do vaccines work against the Delta variant because these are real numbers around the time where the Delta variant has been the main virus out there. So if we look at the number of unvaccinated cases versus those that are vaccinated, we can see that vaccine prevents about 6-fold the number of cases out there. When we start talking about death rates, the protection is nearly 12-fold as high. So especially vaccines are really effective against that severe versions of infections. All right, I think I've hit that point to death. Let's point out numbers from our own hospital. All these people here are people hospitalized, representing that, who were not vaccinated. This is the group that's vaccinated. 78% of the people in our hospital were not vaccinated. 91% in the ICU, 92% ventilated. To point out some numbers, 28% who are not fully vaccinated account for 92% of the patients who are vaccinated. I took statistics. I don't know that we need statistics to show that, what's accounting for things. The thing to point out here is vaccines for the 5 to 11-year-olds became available just last week, basically. And so hopefully these numbers will kind of pop up. But the idea is that this is where that 28% came from for Colorado, because that's the group that hasn't been vaccinated. And that's for 12 and old. That number is probably actually less than that because we don't get a lot of the 12 to 18-year-olds in our hospital. I would mention for people that are concerned that might ask me if my kids have been vaccinated. My kids were part of the clinical trial, and I just found out last week that they were vaccinated. So this is how much I'm pushing vaccines, that even in my kiddos, I am all fully supported, and I've received my 3rd vaccine, as I think pretty much all the other providers at the MS Center have. Where do we rank as far as the world goes? We're not even anywhere near at the top. This issue about vaccines and how we're hogging them in the US, we're not putting them to use if that's the case. All right. So if we look at fully vaccinated, there's countries that are in the high 80%. You know what life looks like in these countries? In Spain, they're going to soccer games without masks on. All right, so where are the vaccination guidelines? Initial vaccination, J&J, it's a vector virus, 1 shot, you're done. Moderna and Pfizer, mRNA vaccine, 2 shots, you're done. Pfizer's 3 weeks apart, Moderna's 4 weeks apart. One of the things we talk about is the follow-up doses. It's okay to mix and match, and as of now, one of the things that we will try and talk about are 3rd doses versus boosters. For 3rd doses, we're talking about this for patients that are immunosuppressed, high-risk environments, or older than the age of 65. And there's a big push in our state right now to basically just get a 3rd dose for everybody. If you're not part of those groups, then that 3rd dose becomes a booster, or that next dose becomes a booster. I call it a 3rd dose because the vast majority of people in the United States have gotten the 2 shots. If you got the J&J, this would really be a 2nd shot. And one of the things to note is that the Moderna booster is a half dose, meaning if you're in the immunosuppressed group, if you're coming in for your 3rd dose, you want a full dose as opposed to that half dose. So just something to kind of think about at this point. But yes, for immunosuppressed, then now we're talking about 4th shots, 6 months after you complete that 3rd shot. So for most of our patients, you're talking 4 shots, and I wouldn't be surprised if this becomes a yearly thing or something along those lines. So let's talk about, hey, I had COVID, do I need to get vaccinated? The answer on our recommendation, the National MS Society's recommendation is yes, you should get vaccinated. Why? Because natural immunity really depends on how bad you got sick from it. If you had kind of a runny nose and kind of maybe fever for a couple of days, and that was kind of the extent of it, for most cold viruses, you can get the same cold virus every couple of years, and COVID, it's no difference. And so meaning your antibodies your immunity starts to come down and you can get infected again. This study, looking at a lot of people, showed that vaccination was 5.5 times better at preventing the next infection than if you had a prior infection of COVID. Okay, so it's not quite the same as getting a vaccination. So we really want to recommend getting vaccine in this group of people. All right, can't have an immunology talk without an immunology slide. So complicated slide, but to kind of point out that we basically have two arms to the immune system. We talk about T cell responses and we talk about B cell responses. For people who know our center, and most of our patients are familiar, we tend to like medicines that take this part out. They're B cell depleting therapies. And this would look traditionally very scary. We were scared. We held off on giving infusions for a few months at the beginning of COVID, trying to figure out how bad does it look and things like that. What we're seeing is that the vaccine responses are really good at keeping this part of the immune system intact, and that this looks 100% normal. If in fact anything, in some of the patients on those B cell depleting therapies might be a little bit higher than 100%, meaning this is trying to take over some of the response from B cells. From a B cell perspective, a few patients can develop B cell responses. And the issue there is that, our drugs deplete the B cells in the blood, but they don't get into the bone marrow very much. And there's still a few B cells floating around that the drug doesn't quite get, really low numbers. So that can kind of help still kind of drive this so that you can get these plasma cells and make antibodies. So this is studies from here. These are our patients. A lot of these were nurses and doctors in the first wave. And we could see that patients on B cell depleting therapies did not make a lot of antibody in the first vaccine. Healthy controls did really well. And again, sort of this difference after the second vaccine, highest response was lower than this. This was replicated with people who had natural infection from NYU in New York City, where the level of antibodies on patients who were on B cell depleting therapies and ocrelizumab were lower than those that were not. When you look at T cell responses, though, really pretty good responses to natural infection as well. All right, these are new data from over the last few months, kind of showing the same thing. So as you look at B cell responses, not as good with either ocrelizumab, although some people do, to about 23%. And here we could see, and this is actually to a third shot. And then here you could see the responses to Gilenya, where it might be a little bit more concerning. But again, kind of on the lower side. If you look at time from last dose, we could see that ocrelizumab, the longer you kind of get away from the last dose, that the better the antibody response was. And so there was a sweet spot between 3.7 and 6.4 months where people could actually respond to vaccines towards the end of the cycle. This is kind of a really big paper that just got published a couple of weeks ago from the group at University of Pennsylvania, showing very similar results from a B cell response where healthy controls develop great antibodies, not so great antibodies. In this case, they saw about 50%, showing that the farther you got from that infusion, I think this is easier to see, that those people that got further out actually made pretty good antibodies to this. When you look at T cell responses, pretty much looks identical. So this is why we're not seeing this huge mortality rate in our patients, because you still have a really good immune response that you can build through this T cell responses. So the question, should I get a booster? Yes. Recommended for those with moderately or severe compromised immune system. So what does that mean from our end? Basically, anybody that is on an S1P drug, so think Gilenya, siponimod, ozanimod, or ponesimod, that's what we're looking at. And again, timing, we want to ideally wait 4 weeks. The closer you can kind of get towards the end. For boosters, we have a little bit more flexibility than the recommendations that we gave earlier in the pandemic, where we're like, just go out and get it. I think now we have a little bit more flexibility because your T cell responses are really pretty good. And to try and help make those antibody responses, we probably should be waiting, towards the end of those 6-month infusion cycles. Again, this is actually after a booster response, so we can see that with Gilenya, maybe those responses weren't quite as good, but about a quarter of patients did develop antibodies after the booster shot. So I'm going to spend a few minutes, and I apologize, I'll go a little bit over, but myths. So mRNA vaccines are new and have a little extra data to support them, and have little data to support them. So the answer is false. This is the new vaccine this is the first time that they've been used, but this technology has been being developed since the 1980s. It's just this is kind of the prime time, and we've not had to develop vaccines this fast for anything else. And so this has kind of been the force behind trying to develop this. Do we have a little data to support this? Worldwide, we've given over 7 billion, with a B, yes, I did say that right, billion doses. I don't know of any other drug except maybe aspirin or a few other things that has more data than we're ever going to get on this. So this issue of like, we don't have data, wake up, is the only thing I can kind of say. They can take a microchip. There's no way a microchip to this point that can track you will fit through a needle. No way. Anybody who's get their dogs microchipped, see how close they have to get to that microchip to develop that. And then look around and see how close you have your phone to you. So if they want to track you, there's other ways to do so. DNA will alter your RNA. RNA goes, the way it goes is DNA to RNA to protein. It doesn't go backwards in the human systems. So you cannot alter your DNA with an mRNA vaccine. Impossible. Can't happen. You will not genetically mutate you. Magnetic, I don't know where this magnetic thing came out. I've checked a magnet against me. I've gotten 3 doses. It still hasn't happened. You can get COVID from the vaccine. This is an important one. You cannot get COVID from the vaccine. The COVID vaccine only makes one of the proteins of the virus. It does not make the whole virus. You cannot get COVID from it. For RMS patients, it becomes an issue because you can get fevers and chills for a few days and some fatigue. And those fevers can drive to have a pseudo flare, and we see some of these. There's been lots of papers showing that we do not see relapses at this point for the vaccine. This issue about sterility, again, big trials at this point, New England Journal paper of medicine that show that there's no effect at all on pregnancy rates or miscarriage rates in MS in patients who have gotten the vaccine. This was probably one of my favorite ones. The vaccine contains that luciferase. There's no component of the devil in the vaccine. There's no 666 part of the patent that is involved with this. If somebody knows more about the Inferno program, let me know. I don't know anything about it. This is a common enzyme used to make as a light reporter, and this was used in developing the sort of the substance, the vaccine. But you're not a firefly, and I've also checked myself in the middle of the night, and I don't glow in the dark. I wish I did, but still don't. It can result in blood clots. This is an important one. This one kind of led to a halt in the J&J vaccine. The rate of getting a blood clot is that. That's a lot of zeros. If that makes you concerned, I hope you're wrapping yourself in bubble wrap and not driving a car to get here or go anywhere else. The chances of getting blood clots, if you have COVID, is really low, but much higher in the order of 100-fold compared to what it is from the vaccine. All right. So we do see strokes, we do see heart attacks with people who have COVID, and part of that's because of the clots associated with that. Ivermectin can treat COVID. Yes, if you're part of a test tube and are not a part of a human being, that is completely true. So will bleach and do a lot of other things like that. The problem is the doses that would take that are much higher than your body will tolerate. And what we're seeing is a lot of people developing toxicities and getting toxic on ivermectin because they're taking literally horse pills, as in like doses required to treat it in a horse or a cow or a pig. And that's what people are taking. And so we're not as big as a horse or a cow. And so people are getting toxic from it. I've gotten past this, so I'm going to skip this slide, but whoever wants to read it, you can go for it. He might have ended up being our quarterback. I hope that doesn't become the case anymore. I'm all for body autonomy, but when you start to make lies about things, I just have real issues about this. And he's paying for some of this stuff now with loss of some of his sponsors. There are some treatments out there, some monoclonal antibodies. These have gotten a little bit more complicated because of the variant. So it's not just that you can get like bamlanivimab or Caris. Anyway, you need these other parts because the virus changed enough that the antibodies that help protect you become important. I think this shows why we care a little bit about the vaccines and the boosters. Antibodies still help us. We still have T cells. Those T cells are helpful, but the first line of treatment when somebody starts to get those mild cases is antibodies. So we want to try and do everything we can to try and build those up. There are some new treatments coming up. J&J just announced on the 5th some interim data of an antiviral that actually will looks like it's preventing death so far. Small cases, 10 deaths in the placebo arm, no deaths in treatment, but this is promising data at least. And then another report here that we can see. So what? So this issue of appear to protect from bad COVID, that's not the case, right? We know vaccines now prevent against bad COVID. We have the data to support that. We've talked a lot about this. My takeaway point is get vaccinated, but get out of the house, exercise. We're seeing a lot of deconditioning and other things like this. Eat right and just be well. All right, thanks everybody.
Thank you, Dr. Alvarez. If you would like to see all of the information on COVID-19 that the Rocky Mountain MS Center has compiled, including previous presentations from Dr. Alvarez and Dr. Corboy, please visit mscenter.org and click on the banner for our COVID-19 education page.